Chair of Translational Research at the Department of Oncology at MD Anderson Cancer Center. He's also the co-director for the Center for RNA Interference and Non-Coding RNA, and is the director of the Blanton-Davis Ovarian Cancer Research Program. So he's had numerous peer-reviewed publications, authored several, and co-authored and authored several book chapters. And today he's going to discuss hereditary and non-hereditary risk factors in the management of ovarian cancer. Dr. Sood.
So briefly today, what I'll do is talk about the risk factors for ovarian cancer and talk about some of the hereditary factors, especially in the context of ovarian cancer. I know Banu is going to talk about breast cancer, I think, today as well. And then we'll talk a little bit about what some of the efforts are under this Women's Moonshot program to try to address, especially some of the hereditary factors, and trying to really make some substantial gains in terms of improving survival. So a couple of things just in a way of introduction, and I'm not going to dwell on this slide because it's going to have a lot of sort of molecular things on it, but ovarian cancer is not one disease. When people use the word ovarian cancer, lot of at times people think, well, just say that all cancers are similar. They're not. Ovarian cancer is a very, very diverse, very heterogeneous disease. Even within a specific subtype of ovarian cancer called high-grade serous that we'll talk about today in more detail, even within that, there are a lot of features that are very, very diverse. So if you click the slide again, so even within ovarian cancer, there is something called a high-grade cancers, and there are low-grade cancers, and these are just very different. They're molecular, their genetic makeup, the way they behave in terms of the course of the cancer, even the kinds of therapies that are used are very, very distinct. High-grade serous type of ovarian cancer is about 70% of ovarian cancers, so it's again a deadly cancer, and that's why we focus a lot of energy surrounding this in terms of improving outcome. Okay. Go ahead next, please. So let me touch briefly on non-hereditary or non-genetic type of factors first in about 3 or 4 slides, and then we'll go into some of the genetic factors as well. So for many years, it's been thought that the number of ovulations that a woman goes through may be related to ovarian cancer, and so the hypothesis or the thought had been that ovulation exposes the surface of the ovary to damage, and as that starts to repair, somewhere that process becomes abnormal and that ovarian cancer may develop. Okay? If you click it one more time, the things that support that are that those women who over the course of their lifetime have lower number of ovulatory cycles. Okay? So examples would be more pregnancies women have had, lactation, birth control pill use. All of those factors are associated with lower risk of ovarian cancer. Okay? This is not a perfect hypothesis. Okay? And there are many reasons for that. And one of the ways in my mind is that if that was true, that ovulation is a dominant factor, but do you see the average age for ovarian cancer in this country is around age 59. Why would there be such a long gap then between finishing ovulatory cycles and the cancer developing? So it's not a perfect hypothesis, but regardless, the evidence related to birth control pills, pregnancies, and so on is real. We've known that for a long time. Okay. Next slide, please. The second reason is that some people think that when women go through the change of life, so through menopause, that there's a shift in hormones, that there are hormones such as the follicle stimulating hormone, that FSH, and related hormones start to become more dominant after the change of life. And some of those may stimulate cancer cells that may be laying around in the ovary. Okay? If you'll click one more time. Now, does this make sense? Well, there's some evidence that women who have conditions where these kind of hormones may be present at higher levels, infertility, polycystic ovarian disease, and so on, there seems to be a higher risk for ovarian cancer, and that even when women use progesterone-only birth control pills, there's still a lower risk for ovarian cancer. So again, there's some thought behind this. Again, none of these are perfect hypotheses, okay? Next slide, please. I get a lot of questions about inflammation. Does inflammation cause cancer? How is it related? And on and on. If you'll click it one more time. So there is evidence that when women use non-steroidal medication, aspirin, related drugs, that there may be a lower risk for ovarian cancer over prolonged periods of time. Those associations also exist, though, for other cancers like colon cancer and so on. Many years ago, there were some studies published that women who use talcum powder on their bottom tend to have a higher risk for ovarian cancer. Okay? And the thought was that these kind of powders may go through the vagina, may go through the fallopian tubes, and actually expose the ovaries to carcinogens and cause inflammation, and that may be related to cancer. Now, in the 1970s and 60s, talcum powders used to contain low levels of asbestos. Okay? That makes sense, it's a carcinogen. But even after that was taken out, the association still holds. There's about a 20 to 30% increase in ovarian cancer risk with long-term. We're not talking about 1 week, 2 weeks. We're talking about thousands of applications over the course of a lifetime. Okay? Then other inflammation-related diseases like endometriosis, very consistent relationship with ovarian cancer. Okay? So these are some of the non-genetic factors that have been related to ovarian cancer. Okay, next slide, please. Now, the thinking behind ovarian cancer is shifting. We used to think that all ovarian cancers were predominantly coming from the ovary. Well, likely that's not the case. That at least a fraction of ovarian cancers are very likely coming from the fallopian tube itself. That has implications, many implications, and we'll talk a bit more about that. And again, some of the molecular stuff, I don't want to go into too much detail, but if you go into the next slide. So the idea is that the fallopian tube, or the distal part of it, meaning the part that sits closer to the ovary, actually in a lot of patients with ovarian cancer has changes within the fallopian tube that would be suggestive of early cancers or precancerous type of changes. Okay? So the idea is that some of the changes may actually be occurring in the distal part of the fallopian tube. Now, fallopian tube is open, so it's not like a big mass can form within the tube unless it's blocked on both sides. So as a result, what happens is that these abnormal cells then drop to the ovary. Why? Because the ovary is sitting right next to the fallopian tube. And these cancer cells then start to implant on the ovary, grow like a mass, and for all practical purposes, it looks like ovarian cancer that started from the ovary. Okay? So the thinking now is that up to 30 to 40% of the so-called ovarian cancers may very well have started from the distal part of the fallopian tube, not necessarily from the ovary itself. Okay? Moreover, for the genetic types of or related ovarian cancers, a high percentage of those likely start from the fallopian tube. Okay? So this is a very different thinking process over the last 5 years, 6 years that has started, but that has many implications. Okay, next slide, please. Now, how much of the ovarian cancer is hereditary? Well, at a broad level, we would say about 10 to 15%. Okay, so 10 to 15 out of 100 patients very likely have some hereditary genetic component to it. Okay, next slide, please. So how does that manifest, and how do we think about it? Some of these slides, my colleague, Dr. Karen Liu, who works very closely with Dr. Arun in the genetic screening clinic, has provided. So here's an example of a family where the proband, meaning the individual, first affected individual, developed ovarian cancer at age 49. And that's not an uncommon presentation when we start to think about cancers that may be that may have a hereditary component. Again, remember the average age I said is around 59. Those families that have genetic links to ovarian cancer tend to present with ovarian cancer about 10 years earlier, okay, on average. Okay? Now, why would genetic testing have implications? How does it work? So if you'll click it one more time. So in this family, for instance, say this individual tested positive for one of the genes that we'll talk more about, okay, for that can be transmitted to her daughters, to her other family members, and so on. Okay, if you click it one more time. Now, say this daughter tests positive for that gene at age 28. Okay, this daughter tests negative for the gene. They're both in their mid to late 20s. What do you do about it? Okay, what implications does this have? Okay, let's talk about that. Okay, next slide. So please go on. Now, the two dominant genes for ovarian and breast cancer risk are genes called BRCA1 and 2. I think Dr. Irwin will likely address some of this as well. All I want to convey out of these is that these are what we call tumor suppressor genes, meaning if you mutate these, if you cause a change, so if you think about this as a book and there is a typo in the book somewhere that causes the whole book, or in this case the protein, to malfunction, okay? That's what happens in the mutations, okay? Now these mutations, a lot of these can be inherited, meaning they can be passed on from one family member to another, okay? What I wanted to convey out of this is that these are not small genes, these are massive genes. So when we look at sequencing these or looking for mutations and so on, it's not a trivial exercise, but it's been now, it's gotten to a point where it can be done and it can be used for clinical purposes. Okay, next please. If there is a mutation in the family that gets transmitted to other family members, so if we talk about the risk for ovarian cancer with just BRCA1 mutation, the baseline risk for ovarian cancer, okay, in this country would be about 1 out of 70, 1 out of 80 women would be affected. But if there is a mutation in BRCA1 gene, all of a sudden you're talking about close to 40% risk for ovarian cancer. That's substantial, okay? And again, Dr. Irwin is going to address the risk for breast cancer, so I'm not going to go into that too much detail. But the point being that those that have an inherited mutation are at substantial risks for developing cancer. Okay, next please. The risk doesn't just happen at in an isolated way, meaning that the risk increases with aging. So if you think about for breast and ovarian cancer, and again, this is important for prevention approaches, because some of the prevention approaches can have substantial implications for women. Okay? You see, at age 30 or younger, the risk is really quite low. But as women age, then the risk continues to go up, both for breast and ovarian cancer. We have to keep that in mind as we talk about then prevention and screening approaches. Okay, next one please. Same thing with BRCA2. BRCA2, again, both for breast cancer and for ovarian cancer, as women age, then the risk continues to evolve or increase. Okay, next please. What are some of the red flags that if you're taking care of an individual and you don't know that they have a mutation? Okay? What are some of the red flags? Well, multiple family members with breast and or ovarian cancer, early onset of breast cancer, less than 50, ovarian fallopian tube or primary peritoneal cancer, okay? Multiple primary cancers in the same person, okay? Breast cancer, breast and ovarian cancer. Triple negative breast cancer, and again, I think Dr. Arnold is going to talk about that. And very importantly, people forget about this, male breast cancer. Okay? If you see breast cancer in a man, you have to keep in mind the risk or having the BRCA2 type of mutation, especially in that given family. Okay? Also keep in mind that in males, prostate cancer can also be linked to BRCA1, BRCA2 genes. Okay? Next, please. Now, what kind of ovarian cancer is most likely to occur with these particular genes? Well, high-grade serous. Remember we talked about that ovarian cancer is not a single disease. It's very heterogeneous, very diverse. High-grade serous type is the most suggestive type of ovarian cancer for these particular genes to be related. Also, endometrioid type of ovarian tumors can also have these things. high-grade serous cancer, much more so than low-grade. To see BRCA1 and 2 mutations being related to low-grade ovarian cancer is very uncommon. Okay? And that about 10 to 15% of high-grade serous ovarian cancers can be related to a BRCA mutation. Okay, next slide. Again, building on the heterogeneity part, germ cell, granulosa, or other stromal tumors really don't have any association known with these two genes. Okay, next. BRCA1 and 2 mutations are very rare in patients with borderline or low malignant potential type of tumors, or even mucinous type of ovarian cancers. Again, do you see that's helpful? When you see certain types of subtypes of ovarian cancer, you need to think more so about these genes. Okay, next slide. Now let's talk briefly about the genetic testing and what its implications and how that goes about. The benefits are that for unaffected women, that it helps you to define what the risk may be, and there are things that can be done. So there's some cancers you can say, well, so what do you do even if you identify that somebody may be at risk? Well, for ovarian cancer, you can actually do something about it, and we'll talk more about that. Okay? Now, so the benefits don't just apply for the person, for the affected individual who's already been diagnosed with cancers. They have benefits for the family members, but also for the affected individual, because now there are therapies that can work much better in patients who have a BRCA1 or 2 mutation. Okay. Next, please. So how could the results be helpful for the daughters? Do you see we talked about the 2 daughters for that affected individual. So the person who tested positive, she could consider risk-reducing options. Okay, and we'll talk more about what those might be. And the person who tested negative, her risk for ovarian cancer is really back to what the risk would be in a general population. She may not need the more intensive screening or preventive approaches. Okay. Now, genetic testing at this point, and it's going to continue to, I think, improve, is that at this point it costs about $4,000 for full-length sequencing for BRCA1 and 2, and that predictive testing for if there's a mutation already known, then for family members you don't need to test the entire gene again. You can test for a specific point, and that's cheaper. Okay, next slide, please. For those women who are affected, there are things that can be done for screening, meaning they're not quite at a point where they may want to consider prevention approaches, but ultrasound could be considered. This is not a perfect strategy. Okay? Ultrasound, we know, can miss things, and that also it can lead to false positives, meaning it on ultrasound you may raise a red flag that something looks like a cancer, it may not be invasive cancer. So it may lead to surgeries that are not necessarily for invasive malignancy. Okay? Next, please. Now, ovarian cancer is one of the cancers where chemoprevention can work. Okay? Birth control pills are a very important chemopreventive agent. There can be about a 50% reduction in ovarian cancer risk in the general population. So women who use birth control pills for 5 or more years can have up to 50% reduction in ovarian cancer. That usage doesn't have to be continuous. It can be for a period of time and stop for whatever reason and resume again and so on. Okay? But the total length of time does matter. Now, there's some concern whether birth control pills could raise the risk for breast cancer. That's mixed data. There are some studies, even in high-risk populations, that suggest that the risk for breast cancer may not necessarily be higher. Okay? But I wanted to just present that to you, that birth control pills certainly are an important chemopreventive approach. Okay? Next, please. Now, risk-reducing surgery, we know this works. Okay? That this can be very effective for women who are at high risk for developing ovarian cancer. One effort that Dr. Liu and others are promoting is that, say if a hysterectomy is done for another purpose, okay, for another indication, fibroids, whatever that may be, in that setting, to consider removing the fallopian tube, okay, even if you leave the ovary in place for maintaining hormonal function, because a lot of, at least a high proportion of cancers do seem to arise from the fallopian tube itself, okay? So prevention, these kind of prevention approaches work, we know that. Again, these are not completely benign because there's loss of hormone production and so on from the ovaries. So there has to be balance. But again, in women who are high risk, these kind of prevention approaches should be considered when childbearing has been completed. When should you consider the procedure? Again, you see age matters. So for BRCA1, that by age 50, there's 11 to 21% risk of ovarian cancer by age 50. For BRCA2, there's about a 2 to 3% risk of ovarian cancer by age 50. So again, when childbearing is completed, then these kind of risk-reducing surgeries can certainly be considered. Okay, next please. Very briefly, in the last about 4 minutes or so, I'm going to show you some large-scale efforts that are being taken to try to target at-risk families. You see, I didn't say at-risk person, at-risk families, okay, in the women's cancer moonshot. Next slide, please. The reason this is called a moonshot, and I get this question a lot, is that our president, Dr. DePino, took some of the terminology from President Kennedy. That speech that President Kennedy made in 1962 was right here in Houston. Okay? And he said that we don't want to study how to get to the moon. The goal is to get to the moon, do whatever it takes to get there. Okay? So the concept behind the moonshot for cancer is that we want to make massive improvements in survival, do whatever it takes to get there. Okay? Next slide. So the moonshot program, it's a strategic initiative to systematically use all the current knowledge and take major conceptual advances, MD Anderson's critical mass, engage partners to achieve this goal, make huge improvements in patient survival. Okay, next please. So there were several cancers selected for today's discussion. Next, if you click it, is that high-grade serous and triple-negative type of breast cancer are combined in their being worked on under the umbrella of women's cancer moonshot. Okay, there's a lot of learning from each other. These teams have to work together. It's not an option that they can just be hiding in their own silo, in their own room or whatever. They have to work together. Okay, next please. So the flagship projects, and I'll tell you about one flagship project, are those that should have an immediate impact on patient outcomes. Next please. They can be implemented without any new knowledge. They should be about deploying, about implementing to make a difference. Next please. They should have broad applicability across both cancers. Next. They should engage the entire community, meaning not just faculty or and so on, but they should engage the families, the patients, everything, okay, at a large-scale basis. Next please. And they should engage the other platforms within the moonshot to provide services that need to be engaged to achieve the goals here. Next please. So the first flagship is designed to have an impact on the family. If you click it. So do you see, I said that about 10 to 15% of patients will have hereditary cancer. That's high enough that we should be testing all patients. So as a part of this program, all women now with high-grade serous or triple-negative breast cancer are offered genetic testing. Okay? We know that 10 or 15% will have a germline testing. With that, we want to reach out to the families and offer screening and prevention approaches with a goal of by 80% reducing deaths in family members over a 5-year period. That's ambitious, that's aggressive. Okay? The idea is that if you can keep these cancers from developing in these high-risk families, of course you're going to have an impact on this disease. Okay? Next please. So the second part of that project is, again, based on offering testing to all patients. We know that about 20 to 50% of patients will have alterations in these pathways, not just mutations in those two genes, but also the related genes. Why is that important? If you click please. We know that PARP inhibitor-based therapies are particularly active in these individuals. We can build on that. We can have an impact on their outcome based on improving these therapies. Okay, next please. So this is again a broad project. Today I just talked about the genetic screening and its implications, but there are many projects now that are being launched as a part of the moonshot, but the goal is clear, that it has to have an impact on patient survival in the near term. Okay. All right, next please. So in summary, 10 to 15% of ovarian cancer tends to be hereditary. BRCA1 and 2 are the two dominant genes that play a role in this hereditary component. Genetic testing is recommended for now for all patients with high-grade serous ovarian cancer, and that after BRCA1 or 2 genes are found, that family members can also have testing and then offer screening prevention approaches to those individuals as well. Okay, with that I'll stop, and I don't know if you wanted me to.
So Dr. Sood, as far as my background, my mom, she got diagnosed with ovarian cancer about age 60. She had a complete hysterectomy 20 years ago. They kept her ovaries intact because of the hormonal thing that you just mentioned. So I am her only daughter. So I have breastfed my two boys for about 3 years collectively. I have been on birth control pills for about 6 years and plus. And what I'm trying to understand is, given all these statistics, what is my risk should I be testing for my BRCA and 1 and 2?
Luciana, what I try to do for a very personal question, if it's okay with you, let me handle that outside of a public forum, because we want to be careful about confidentiality and things like that. I'd be happy to discuss with you, but let me do it at a non-public forum.
Okay. Because the only thing that I'm trying to understand is, given all this information that I or anyone like me has, what is the step that we need to be taking? Should we go to the doctor and say, test us for a BRCA1 or 2, or just leave it be because I have done all those, preventative techniques that you just mentioned?
Ideal is to test the affected individual first.
Which in my case is not relevant.
I understand. The reason that's important is because, say that a non-affected individual gets tested without ever testing the affected individual, you don't know whether there was a mutation that was not inherited or there wasn't a mutation to start out with. So the information is imperfect in that setting at best.
Okay. Yeah, I'll talk to you offline.
Yeah, of course.
I have a question. So is this a pretty mathematical model? So if you have someone, so you say it's 85%, so you start with a 0.85, multiplied by you've taken a birth control pill 5 times 5 years over, and you multiply that by another 0.5. You keep multiplying, so you get a probability, depending on the test, of what is that person's unique probability of having ovarian cancer.
If you integrate all the other approaches, number of ovulatory cycles, the number of pregnancies, birth control pills, I wish that things were that precise that we could say, incorporating all the other factors for a given individual. I don't think we're there yet, okay? And I don't want to mislead about that. I think it gives you overarching ideas on a population-wide basis. For a given individual, we do a lot better with gene-based information in terms of what their risk is.
Would it, in terms of that big moonshot idea, even if you do it at an individual basis, say this person's really, really low risk, whereas this person's coming up to be at much higher risk, does that feed into the bias?
Of course, and we want to discover. You see, it's even broader than that, because we know that BRCA1 and 2 genes, they're families where you'll see family members or multiple members being affected, but you don't find a BRCA1 or 2 mutation. Okay? So there are likely to be other genes that we haven't discovered fully yet that we need to consider. So one of the efforts in the moonshot is to also discover what are some of the modifiers that dictate risk. So do you see, it's not like 100% of the individuals who have a particular mutation are going to get cancer. Okay? There are clearly modifiers that we need to understand better.
I have a question. I know of a family that female reproductive issues run in the family, not necessarily cancer, but different cysts and growths and things of that nature. And they have had a lot of partial hysterectomies as a preventative measure. And my question is, in an ideal setting for the testing, there are several female family members. Would it be ideal to test say, 3 sisters that have been affected by possible cancerous type of diagnoses, and then test, like she was saying with her and her mother, and you were saying you need like a control to see what you're comparing to see what the levels are and are not. So would that be an ideal situation to be able to test maybe the mother of the individual, them, and maybe 1 or 2 older female adult members of the family to do a comparison?
No, it's a good question. So again, in that kind of a setting, the affected individual who's had an invasive malignancy or who's had an invasive cancer would be the first person to test. So, and that's exactly why we are now offering genetic testing to all women who've been diagnosed with invasive high-grade serous ovarian cancer or the triple negative type of breast cancer. And then based on that information, then expand to the other family